Today, we'll be discussing a comprehensive overview of Sjögren syndrome, an autoimmune condition that is both under-recognized and highly impactful on quality of life. We'll explore its definition, pathophysiology, clinical spectrum, diagnostic strategies, differential diagnoses, management, and long-term follow-up. Before we begin, this video is for education and inspiration only. It's not medical advice. Be sure to consult a healthcare professional and double-check information with trusted sources. Sjögren syndrome, or SS, is a chronic autoimmune disorder characterized by lymphocytic infiltration and progressive destruction of exocrine glands, most notably the salivary and lacrimal glands. This results in the hallmark symptoms of dry eyes and dry mouth, referred to as SSA symptoms. Now, SS may present as primary Sjögren's when it occurs on its own, or secondary Sjögren's when it's associated with another autoimmune disease, most commonly rheumatoid arthritis or systemic lupus erythematosus. We see aberrant B and T cell activation, formation of ectopic germinal centers within the glands, autoantibody production, most notably anti-SSA and anti-SSB, and progressive destruction of exocrine tissues via cytokine-driven apoptosis and fibrosis. A crucial clinical point: patients with Sjögren's carry an increased risk for non-hodgkin B-cell lymphoma, particularly MALT type. Sjögren's primarily affects women, approximately 9-to-1 compared to men. The peak age of onset is between 40 and 60 years old. In terms of prevalence, about 0.5 to 1% of the general population is affected. The most common symptoms are exocrine-related: dry eyes with burning, itching, or foreign body sensation, and dry mouth, which can impair speech, taste, and increase dental caries. Parotid gland swelling is also common and may be recurrent or persistent. But beyond the glands, up to a third of patients develop systemic manifestations, including arthralgia or non-erosive arthritis, interstitial lung disease, often encype or lip, renal involvement like interstitial nephritis or type 1 renal tubular acidosis, peripheral neuropathies, cranial nerve dysfunction, and even cognitive issues. Also worth noting, skin vasculitis, cytopenias, hypergammaglobulinemia, and gastrointestinal issues such as dysphagia and autoimmune hepatitis. Diagnosing SS is multifactorial. Key serologic markers include positive ANA, anti-SSA and anti-B antibodies, elevated ESR and polyclonal hypergammaglobulinemia, RF in 50 to 70% of patients, and low complement levels, particularly in systemic disease or cryoglobulinemic vasculitis. Ocular testing includes the Schirmer's test. Tear production of less than 5 millimeters in 5 minutes is abnormal, and ocular staining with rose bengal or lissamine green. Salivary gland testing may include unstimulated salivary flow rates, parotid imaging via sialography or scintigraphy, and the gold standard, labial salivary gland biopsy showing focal lymphocytic sialadenitis with a focus score 1 per 4 millimeters. Let's quickly touch on the classification criteria. A score of 4 or more is diagnostic. This is a weighted system. Biopsy with lymphocytic sialadenitis, 3 points. Anti-RUS activity, 3 points. Ocular staining score, 5, 1 point. Schirmer's 5 mm, 1 point. And unstimulated salivary flow, 0.1 milli per min, also 1 point. It's essential to rule out other causes of SSA symptoms: Codosis, IgG4-related disease, chronic infections like HCV or HIV, medication effects, especially anticholinergics, radiation injury, and systemic causes like amyloidosis or GVHD. Management is split into 2 domains: symptomatic relief and treatment of systemic involvement. For ocular symptoms, we use artificial tears and nighttime lubricants, cyclosporine drops, Restasis, or Lifitegrast. For oral dryness, saliva substitutes, sialagogues like pilocarpine or cevimeline, and vigilant dental care. When it comes to systemic disease, hydroxychloroquine is often first line for fatigue, rash, and joint pain. Corticosteroids are used in moderate to severe disease. Immunosuppressants like methotrexate or MMF for renal or pulmonary disease. and rituximab is reserved for severe or refractory cases, especially in cryoglobulonemic vasculitis. Complications of Sjögren's can be far-reaching. Dental caries and oral candidiasis from xerostomia, corneal ulceration from severe dry eye, interstitial lung disease or bronchiolitis, RTA from renal involvement, and critically, lymphoma, especially malt lymphoma. Patients at higher risk have persistent parotid swelling, low C4, monoclonal gammopathy, or cryoglobulinemia. Ongoing monitoring is key. Regular physical exams for lymphadenopathy or gland enlargement, labs, CBC-CMUA immunoglobulins complement levels, annual dental and ophthalmology checks, and close observation for lymphoma signs like night sweats, weight loss, or glandular mass growth. The prognosis for gland-dominant SS is generally favorable. However, in patients with systemic manifestations, the disease course can be more unpredictable and requires close, often multi-specialty follow-up. Lifelong surveillance for lymphoma is essential. So in summary, Sjögren's is a multifaceted autoimmune disease with both SSA and systemic involvement. Diagnosis is supported by serologies, glandular testing, and biopsy. Management ranges from local symptomatic care to immunosuppression for organ involvement. Lymphoma surveillance remains a vital part of long-term care. Thank you for your attention. Please let me know if you'd like to dive deeper into specific systemic manifestations or review newer therapeutic trials related to SS.